Good evening, everyone. I'd like to welcome everyone back to the Lipid panel. My name is Dr. Guy Mintz, and I am the co-chair of programming for the Lipid panel, working with Dr. Merle Meyerson and Amanda Hicks. The Lipid panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky to work in large medical centers, we'd have a lipid clinic or colleagues down the hall that we can discuss cases with. But for many of us, we don't have the luxury of having lipid specialists so close. So using the lipid panel concept, we can bring cases to everyone throughout the United States. For the rest of us who feel we're on lipid islands, conferences like this remind you that you are not alone. If you have any cases that you would like to be presented at future conferences, please email Amanda Hicks at ahicks@lipid.org. In this series, we review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions, and we'll try to cover as many important clinical topics that every lipid specialist needs to know. The series is meant to be a monthly coming together of rising stars like our FNLA scholars and other seasoned professors in various specialties to help us understand complicated topics within the lipid world. This evening, I am joined by an expert lipid panel. We'll be discussing the role of coronary artery calcium scores. I will be moderating this evening. I'm also the Director of Cardiovascular and Health, Lipidology, and Lipid Apheresis at Northwell Health. We're joined this evening by Dr. Jonathan Ahn, who is a non-invasive cardiovascular imaging fellow at the Brigham and Women's Hospital and the Harvard Medical School. He will be presenting our cases this evening. We're honored to have Dr. Matthew Budoff with us. Matthew is a professor of medicine at the David Geffen School of Medicine at UCLA and the Endowed Chair of Preventive Cardiology at Harbor UCL Medical Center. Dr. Budoff is a graduate of the University of California, Riverside, and graduated as an AOA member from George Washington University School of Medicine. Dr. Budoff has authored and co-authored more than 50 books and book chapters and more than 1,000 articles. We're also honored to have with us this evening Dr. Khurram Nasir. He is the William A. Zurobi Centennial Chair in Cardiovascular Health, Professor of Medicine at Weill Cornell Medical College, and Chief of Cardiovascular Disease and Prevention and Wellness at the DeBakey Heart and Vascular Center at the Houston Methodist Hospital. He's director for the Center of Cardiovascular Computational Health and Precision Medicine at Houston Methodist Hospital. So it's an honor to have such a distinguished panel with us this evening. I welcome questions. People can put their questions in our Q&A section, and we'll be happy to answer them throughout the program. So without further ado, I'd like to start the program and have Jonathan present our first cases.
Thank you so much. And it's just a true honor and privilege to be here today. So we'll get started with our first case, but we realize that coronary artery calcium, it is a surrogate for coronary artery atherosclerotic burden. And that amount is associated with the burden of atheroma, but the mechanism of calcium deposition into plaque and that process is not fully understood, but we hope to shed light on this and help improve your clinical and diagnostic avenues for the treatment of your patients. So in this first case, this coronary artery calcium score, this is a 55-year-old Caucasian female with essential hypertension on lisinopril 5 milligrams. There's no family history of coronary artery disease, and the patient does not want to take a daily medicine unless it's absolutely necessary. Utilizing the ASCVD risk score calculator that takes into account a patient's age, their sex, their ethnicity, whether they're a diabetic or a smoker, their systolic blood pressure, and then whether or not they're on medications for blood pressure are all taken into account for this patient. And an ASCVD risk score over a 10-year period has been calculated at 2.3%. The lipid panel here is provided for your review with a total calcium, that TC at 225, the HDL at 71, LDL at 128, triglycerides at 132, and a non-HDL at 154. So who is the appropriate person to test? And generally, we look for patients that are between 40 to 75 years of age with an LDL that is between 70 to 189, and they have a 10-year ASCVD risk of 5 to 19.9%. So this example would not necessarily be the appropriate person to test, but if they did meet criteria, CAC may be useful to help guide whether or not therapy or the intensification of preventative therapies would be warranted. And so this is an example of a coronary artery calcium score where slices are generally at 3 millimeters thick and an average of 50 to 60 slices. This allows us to view the entire ostia, the mid portion, and distal coronary arteries. It's also important to note that we're careful to not select calcium that is within the left ventricular outflow tract or on the mitral valve itself. During this test, when we're looking at coronary calcium scores, we're also taking into account the aortic dimensions at the level of the pulmonary artery. And we can also get a gross assessment of the pulmonary artery to see if it's enlarged. Although not as exact as a CT, it does give us a general assessment. This patient had no coronary artery calcifications. They had an Agatston score of 0, and the 10-year risk of cardiovascular disease events for this patient would have been at around 1.8%. And so this is the first case, and I open it up to our panel to give feedback on the power of 0, if anyone would like to chime in on this.
Khurram, you want to take lead?
Yeah, so, as Jonathan, you rightly pointed out, the pretest probability or the risk based on the PC is on the lower side. If you look at the guidelines, and again, guided by some of the work that Matt and I and others have done, that's shown that if your 10-year risk is less than 5%, almost there is an 80% probability that the calcium score would be 0. And hence the guidelines kind of accounted that and suggested that may not be the best population to test because the yield is higher. But that said, there is still 1 in 5 probability of these individuals having early atherosclerotic disease. That means that the process has already started. And if you're even looking at the short intermediate term, their risk may be 7.5% or more. So in essence, I don't think so. This is a case where a calcium is not accounted. Of course, it reassures, but if it has, then it at least moves the needle in a direction where early initiation of lipid-lowering therapy without the need of an aspirin and trying to get their lipids under control would be a factor. Now, I would say this may not be the ideal case to highlight the power of 0. I think so the power of 0 is going to be much more important in the intermediate and maybe slightly moving into the higher risk group where an absence of calcification can move the needle for reclassifying them lower, possibly avoiding statin or de-intensifying the therapies that would be needed. For this person, even if I would have gotten a calcium score, would have been more trying to see if they have any early plaque. So early initiation of preventive therapies could be warranted.
And I would just add, for me, it's very reassuring. I would say I wouldn't scan them again for 5 years, and I wouldn't treat them or consider treatment for the next 5 years with statin therapy unless something changed significantly over that interim period. And that's consistent with the guidelines from 2018. And even in the appropriateness guidelines for imaging in 2023, this category of patients, low risk, said may be appropriate. It was not considered inappropriate to do a calcium scan here. So I think it's reassuring for the patient. It's reassuring for me as the clinician. And I'd be very happy and tell the patient, let's eat well, do the essential 8s for lifestyle, and we'll test you again in 5 years.
There was a question from the audience. What are your thoughts on quantitative plaque analysis to assess severity of a non-calcified plaque? Any role for it here?
So I would say this patient is too low a risk. I think the yield would be very, very low from both a risk assessment and from a calcium score of 0 assessment. I'm not a big advocate of taking people who I expect to have a 0, who have a 0, and doing more testing on them. So if they were, we could talk more about FH or diabetes. If they had a score of 0 and I really wanted to make sure that I wasn't missing something, if they were very young, under the age of 40, I would think that would be a place where CT angiography and quantitative plaque assessment might be helpful. But this almost at least 99% chance they're either going to have trivial or no plaque at all. And I think that would lead us to the same answer. Let's wait 5 years and reconsider.
And I would echo Matt's sentiment here. If you look into the general population, of course, as one of the study, which is the Miami Heart Study, and Matt was the core lab, almost the same age population, age 40 to 60, or almost about 10% individuals with a calcium score of 0, yes, did had exclusive non-calcified plaque, but I'm sure Matt would give his insights that almost exclusively those were like a streak in one segment. And truly, even from the large cohorts, even in the higher risk symptomatic individuals like Scott Hart and even Promise, in an absence of a calcium score of 0, the risk is minimal. So for a person like this, the added cost, I don't think so radiation is the issue that would add significant risk stratification, and lifestyle optimization and repeating the test in 4 to 5 years seems to be an appropriate strategy.
Okay, great. All right, Jonathan, do you want to start with the second case then?
Yeah, absolutely. Thank you all for that feedback. That was great. So with the second case here, we have a 61-year-old Caucasian female with hyperlipidemia and essential hypertension. She's on losartan and HCTZ. She has a history of preeclampsia. There was a fatal myocardial infarction in the father at the age of 52, and more of a borderline risk at around 5.3%. And the values that were used to calculate that score are provided in the lipid panel here, with a total cholesterol of 181, an HDL of 45, and an LDL of 120. And so this was the coronary artery calcium score for this patient. And again, the density is measured in Hounsfield units, where a score of 1 is generally for 130 to 199 Hounsfield units, 2 for 200 to 299, 3 for 300 to 399, and 4 for 400 Hounsfield units or greater. And that weighted score is multiplied by the area. And this score provides us what is called an Agatston score. And this is then converted to a percentile rank that is based on both age and gender. And for this patient, it was around 35. And you can appreciate the distribution here, 35 overall with left main as a 1, the LAD at 18, the left circumflex at 1, and the RCA at 15. And the observed calcium of 35 was at the 42nd percentile, meaning that 42% of patients at this age and gender had less calcium than what was detected in this study. So what is the feedback regarding this case?
Well, before you go to that, Jonathan, can you just go back to her profile? Or
Absolutely.
Okay. So, in terms of a 61-year-old female with a borderline risk at 5.3%, I don't know, Matt, if you want to comment, or Khurram comment on what would push you to even do a calcium score in this asymptomatic person, since she's low risk.
I think when we talk about this borderline risk, this is really where I think calcium scoring really helps me, and I think helps the patient as well. She has a family history which doesn't really calculate into that risk, so you might and preeclampsia. So she has a couple risk enhancers that would make her probably a little higher risk overall, at least in most of our minds. And I think that when you see an LDL of 120, you start getting a little nervous in somebody who has multiple risk factors and now a family history of heart disease. So I think, if she had a score of 0, I'd be very comfortable saying, you know what, you didn't get dad's genes, you're doing okay. Let's keep that blood pressure under control, diet, exercise, and let's keep an eye on things and not start a statin. I think now that she has established atherosclerosis with a calcium score, it's not a high score, but I think it's a reasonable place to get started. And now at least treat her LDL. I don't think she needs to go to an LDL of 50, but I think a statin to get her LDL well below 100 would be very reasonable from my perspective. And I think she would become a better patient. She might exercise a little more. She might lose a little bit of weight if she's overweight. And she certainly can keep an eye on her blood pressure a little more carefully, knowing that she does have some atherosclerosis.
So, I'm going to add a little completely agree with Matt. And again, these are, I would say, the ideal patient where the calcium testing can act as a tiebreaker. Clearly, if where the power of zero would have been extremely useful in reassuring the patient, possibly delaying and even avoiding the statin. Now, clearly what the patient has declared that the atherosclerotic process has started. It's early, but I may want to go back to the image and the total results back again and saying, apart from the total result, I think there are a few components that I like to pay the attention to. One, within this low score, a couple of things. One is the distributive nature of the plaque. So you can have, now studies are well shown that for the same amount of plaque, if you have in one artery versus 2 to 3 or more, the risk is slightly much more higher. And clearly it is a distributive nature rather than one large segment of plaque. So in my view, this may be a more genuine atherosclerotic distributive process where the risk may be higher. So Matt, I may even definitely be inclined in pushing towards a high intensity and trying to lower our LDL below 70, just because of the nature of the score distribution, although the numbers are low, but definitely the characteristics suggest that she may do well with more intensive management.
I completely agree. I think once you've made the decision to treat, which wasn't obvious from a risk assessment of 5.3% in a middle-aged woman, I think now you have a compelling reason to treat, and why not try to see if she can tolerate the highest potency statin? I don't think I'd rush to get her on dual therapy or triple therapy with ezetimibe or PCSK9 or bempedoic acid quite yet, but I do agree with being more aggressive with her LDL management.
So Matt, one question for you. How much weight do you put in the distribution and the number of plaques when you're looking at this low intermediate scores?
Yeah, and I think your point was spot on. I think, the concept that a more distributive pattern is worse makes sense. Think of each of these little specks of calcium. You see 3 of them on that image as being microscopic plaque ruptures that are now healing. Calcium's actually probably part of the healing process, but the only way you get healing is if you have, scar and specks of calcium. And Jonathan, I don't know if you want to play the movie, you can kind of see the calcium distribution there while we discuss, but you see the LAD calcium, and you'll see a little bit more on the aorta itself, which is common in women, and maybe a slight risk enhancer as well, and then some distal coronary calcium. But if, in the aortic, ascending aorta, she has calcium as well, and that would probably be another consideration for risk enhancement. So I think putting it all together, she's had multiple little plaques that have ruptured. She has aortic calcification. She's, at least intermediate risk or low intermediate risk to start, and probably higher than that in reality. And I think being aggressive and being on the more aggressive side would make a lot of sense in this patient. But again, if you showed me a calcium score of 0, I'd pat her on the back and say, see you in 5 years. Just, eat well, exercise, and keep an eye on your blood pressure.
It's great. I think everybody's made some wonderful points. We have some questions from the audience, but I just want to highlight, so you have this patient with an LDL of 120, and many of us see those patients. I just want to do it with diet alone. I don't need any medication. I don't want to do, I don't want any more evaluation. So I think Khurram made a great point that, calcium score is a tiebreaker. If the doc's not sure or the patient's not sure, using the calcium score can certainly enlighten the patient and the physician. So there's a question here. We'll put them all together. Can you explain the significance of a calcified versus non-calcified plaque? Whoever wants to take that for the audience.
Sure, so I'll get started. Yeah, so, calcified plaque or mixed plaques are more consistent with future risk. So there have been some very large studies, excellent registries out of Denmark, showing long-term risk. If your calcium score is 0, even if you have mild soft plaque with a stenosis less than 50%, that you do not have an increased risk of events. So I'm a very strong believer that isolated soft plaque, unless in large quantities causing significant obstruction, is not a very significant problem. Keep in mind that the vulnerable plaque, as we describe a plaque that may rupture, one of the components is spotty calcification. So, to rupture that plaque, you need shear forces. And I always equate a small calcific focus as kind of dropping a pebble into a bowl of jello. It would split the jello wide open because now you have something hard like calcification and something soft coming together. And that's really what Dr. Vermani out of Washington, D.C. is probably Renu Vermani, one of our preeminent cardiovascular pathologists of our generation, really has demonstrated over the course of her career that it's these mixed plaques and these microscopic calcifications that can really lend itself to more risk. And that's why I don't rush to do a CT angio when there's a score of 0 and saying, oh my gosh, I see a 20% or 10% lesion in the LAD. I better get on high dose statin therapy. I say you have a calcium score of 0, let's wait and keep an eye on it. And when you have something more substantive, we can then move forward with treatment.
You want to add anything to that, Khurram?
I think so. Matt has completely given the whole scenario. I would say another factor added that all non-calcified plaques are not created equal. If you do a deeper analysis, either with IVUS OCT and even with CT angiograms, almost majority of them are fibrous and hardly are where I call low attenuation, low Hansfield unit, and more fatty. And for me, in an absence of the calcification, seems like they are less likely to be metabolic active, and hence either progress or rupture or cause events. And hence, if you look at the data as far as ruling out ACS or even obstructive disease, but more importantly, even long-term outcomes, even in higher risk symptomatic patients, you hardly see any events with the calcium score of 0. So for all those purposes, if I don't see one, unless there is a compelling reason, definitely CTA, at least the next step as doing a CT angiogram doesn't seem to be feasible or prudent for me.
Okay, great. Question here, is there a correlation between CAC scores with different levels of lipoprotein A, and should the patient have had a lipoprotein A level done?
Yeah, so I can start that. So from whether the patient's starting with should have a lipoprotein A, I think absolutely yes. Again, a strong indication with the family history. If that lipoprotein A is elevated, A clearly enhances the risk of the patient. Another reason why the patient should have a calcium score, but not only that, but also implication for cascade screening that goes in. So I see lipoprotein A, especially if you have a family history of premature heart disease, for 3 reasons. Number one, get a calcium score. If they have atherosclerotic disease, further intensifying the management, and 3, cascade screening. Now, if the question is how they are correlated, I can tell you the correlation is not that strong, almost on the lines that we see with the lipids. I would say a weak association. And the third point that always comes up, what happens if your lipoprotein A is elevated, but you have a calcium score of 0? So in the large MESA study, at least what we found that even among individuals who had elevated lipoprotein A, but had a calcium score of 0, that did not confer an increased risk. However, if you had a lot of atherosclerosis at baseline and you had elevated lipoprotein A, the risk was significantly magnified. And it makes more sense because that can explain the biology, progression of the plaque, and making plaque more unstable. So in essence, even among those with elevated lipoprotein A, if you have a calcium score of 0, it's very reassuring.
And I just want to remind everybody what Khurram and I and the rest of these presentations are talking about are asymptomatic patients. Yes. So if you have symptoms, then the CT angio, I think, is a much better test. And I would have less confidence in a calcium score only algorithm, although over age 45, a calcium score of 0 still portends normal or near normal coronaries. We're really talking about the asymptomatic person and in this context today. So I just want to keep that in mind as we think about where CT angio symptomatology, calcium score asymptomatic patients when we talk about testing algorithms.
And I think the important piece of this particular case is she does have a risk enhancing feature in the 2018 guidelines, gave us risk enhancing features to consider to push a decision if we need to do further testing or do we need to initiate treatment. So I think that's one important point here. And as I said earlier, a lot of our patients will not sign on for medical therapy initially. So I think that's a great point.
While this is here, I mean, I would just say her blood pressure choice. I'm not ecstatic with a high dose hydrochlorothiazide, and blood pressure, you can argue, still could use a little control. So as we start thinking about more coronary calcium, the questions of intensification of blood pressure, lifestyle, and her score is too low, I think, for an aspirin tablet. But I think we can discuss that with the next case. But I think I would probably think about her blood pressure as being suboptimal at this point as well, given her calcium and distribution.
Okay, great. Let's see. All right, I think we can go on to the next case, John. And
okay. And so this third case, this is a 60-year-old Caucasian male who has rheumatoid arthritis, mild aortic stenosis, obesity, and essential hypertension, on medical therapy with an ARB at 20 milligrams, known history of dyslipidemia, and is reluctant to start statin therapy. The 10-year ASCVD risk is also borderline for this patient at around 6%. Total cholesterol at 235, HDL at 97, LDL at 121, triglycerides at 85, ApoB at 110, creatinine at 1.7 with a GFR of 49. And again, this is an asymptomatic patient and has had no prior stress testing. And here you can...
John, just go back to the profile before we get into the images.
Yeah, absolutely.
All right. So just, to highlight here again, other risk enhancing features we need to be aware of in this particular patient: rheumatoid arthritis, and also chronic kidney disease also showed up in the 2018 guidelines. It's something that's important for us to consider. Biomarkers, the ApoB is elevated here as a standalone. And of course, the lipid panel is interesting. We could talk about that later. And that the HDL is elevated, the LDL is 121.
So Dr. Mintz, just to add on your thing, this is just one of a great example that's highlighting the discrepancy of what you and I would see a patient in clinic and consider them a higher risk, whereas what's calculated on the PCE clearly with underlying significant inflammatory conditions, CKD, even the mild aortic stenosis where the process of calcification happening and obesity. Apart from calculating the CV risk score, I would definitely have them, I would say, more of an intermediate to a high risk than a borderline risk score. So clearly the clinical acumen and your insights shouldn't be overcome just by the 10-year ACVD risk score, which is very heavily weighted on age. All the patient would have needed a couple of more years to be considered intermediate risk.
Great. All right. You're right. All right, John, why don't you show us the images?
Yeah, the drum roll. So I think everyone got a short preview of this, but a calcium score of 1250. And this goes back to distribution mattering, suggesting a higher risk versus more localized distribution. And we know that a left main coronary artery with greater than 35% suggests a higher risk patient in comparison to the other territories that are involved. And again, this is an asymptomatic patient with no prior stress testing. And with a CAT greater than 1,000, we know it's reasonable to use high-intensity statin therapy. This patient was reluctant to start a statin over concern for myopathies. And so I posed to the group, what other pharmacotherapies would the group support? Would colchicine be a reasonable option for this person? Would Repatha be under consideration?
So, I would say if they obviously, high potency statin is critical. I think an aspirin tablet is also indicated. There's excellent data now that at least observational studies, not randomized trials, but very good observational studies, that an aspirin tablet in the setting of a calcium score above 100, the risk benefit favors aspirin therapy. So I would use low dose aspirin and institute that. Might not be bad for the inflammation and the rheumatoid arthritis either, although that kind of a low dose to really get any anti-inflammatory effect. But I do think that a high potency statin and a 81 milligrams of aspirin would be where I would start. Blood pressure was excellent. So I might stay there and see the response. If they're not willing to take a statin, we have bempedoic acid. I would probably use the combination. His LDL is 120, so I'd probably use the bempedoic acid ezetimibe combo or a PCSK9 to get his LDL down, definitely below 70. And I think many people would even target 55 milligrams per deciliter, given his extensive calcification. His risk is very, very high, both based on distribution and the high calcium score. His event risk is very elevated.
So I would say, agree with Matt, this is a very high risk patient, and somewhere I would consider almost CV equivalent. And clearly, Matt has shown that if your calcium score is more than 300, you almost get to reach to somebody who already had a heart attack. Many prior studies have also shown that with the calcium greater than 1,000, your risk may be as high as 30% 10-year, almost getting to a 4-year. So we have a very clear protocol. Anyone with the calcium more than 100 and definitely more than 300, we treat them as someone who is CV equivalent. For a greater than 1,000, I would categorize them as high-risk CVD, targeting their LDL below 55. So our protocol is push for a high-intensity statin if we can. If we are unable to, then add the non-statins and trying to get their LDL below 55. Aspirin, considering based on their CV risk equivalent and the benefit-risk ratio is greater, at least from the observational studies that have been suggested. We'll try to target their systolic blood pressure less than 130. I would even consider non-statin therapies like icosapent ethyl if the triglycerides were elevated, which is not in this case. And if the patient was diabetic, definitely a much stronger reason for considering an SGLT2 and a GLP-1. So for me, this is the tip of the iceberg, somebody that needs to be treated very intensely. I would love to see that what is the patient's lipoprotein A levels, and would strongly encourage cascade screening and at least calcium testing in their first degree relatives, especially the siblings. So again, not only that the patient is at risk, I think there may be an element that we need to rule out, that whether the Lp(a) is not elevated, and if that's the case, also encourage cascade screening.
And certainly with the presence of aortic stenosis, you would also think the LPA could be elevated as well. So, another question comes up. So you have your CAC score of 1,250 with the LAD 283 units and the CIRC 311, right coronary 634. Would you go right to a cath with this patient to really look for a significant lesion?
I'm not a huge advocate of asymptomatic people going to the cath lab. I have to say, if he's truly asymptomatic, I might re-ask questions and make sure that he's not having some type of anginal equivalent that he's not really being forthcoming about. But if he's truly asymptomatic, I would either just treat aggressively and leave him alone, or if you really wanted to, you can do some type of functional imaging to look for occult ischemia. But given the results of Courage and ischemia and the fact that he's asymptomatic, I think it wouldn't change my management much, to be honest. I would still just be aggressive with his medical therapy, and I would be expectant. If he develops chest pain, sure, cath him, no doubt. But if he's asymptomatic, I think you just treat him aggressively, and he may never develop symptoms. It's very possible that he can go a long time with good medical therapy and never switch over to being a symptomatic patient.
Yeah, this is definitely our strategy to Matt. Like if they are completely asymptomatic, especially if they participate in some exercise programs, biking, running, exercising. Now, the challenge happens if you're coming with more sedentary conditions and you push them and there are some atypical symptoms, then it becomes a little hard. Until and unless you truly have typical anginal symptoms, direct cath is not definitely what we do. For the pure asymptomatic, no further testing. Now, definitely, if you're considering functional imaging, I would caution that a stress myocardial perfusion imaging in these patients can potentially cause a more, I would say, balanced ischemia. It's well demonstrated that you're going to see a lot of that. So in the case that there is any interest in functional imaging, maybe a cardiac PET that can also evaluate myocardial blood flow may be a better choice. But if they're completely asymptomatic, I don't think there is need for any downstream testing, especially as Matt pointed out, based on courage and ischemia, you want to intensify the treatment. That is really CV risk reduction. However, if you're looking for any risk stratification, if you're unsure of anginal equivalent symptoms, then consider a cardiac PET rather than a stress myocardial perfusion imaging.
Great. One question, which I think you've already answered, what would be the LDL target for this patient? And certainly would be at least less than 70, and one could argue even push below 70 with these findings.
Yeah, there's some wonderful data from both Mike Blaha's lab and my lab and Mesa that show that calcium scores above 300 are secondary prevention, equivalent to post-MI or single event, and a calcium score above 1,000 is comparable to multiple events, so a very high risk patient where they've had 2 or more cardiovascular events or multiple vascular beds with obstructive disease. And you really, I think, want to get down at least to 70, and I think 55 milligrams per deciliter is quite prudent. And I think reinforcing this concept, and this is where the new diabetes and cardiorenal guidelines for American Heart Association, the PREVENT algorithms, start talking about stage 3 ASCVD, which is subclinical atherosclerosis. When your calcium score is this high, consider GLP-1s, icosapent ethyl, and PCSK9s, as Khurram outlined. So I think all 3 of those, in this case, just the PCSK9, but again, low threshold if they're diabetic for a GLP-1, for ASCVD protection as well, and a very low threshold if their triglycerides are above 150 for icosapent ethyl. For me, I still believe that's a great add-on therapy. And I love the concept of colchicine. I think this guy would be a great candidate for low-dose colchicine. I think this fits right into what we know about high-risk ASCVD and where colchicine may really benefit a patient. So to revisit your earlier comment about colchicine, I think this is that would be a brilliant next move in this patient.
So Matt, one thing that caught my attention on the labs was the HDL of 97. And, the interesting thing is the HDL story is really evolving. And of course, now we clearly have indications from multiple sources within US and Europe and Denmark about the U-shaped curve, where especially in men above 80, the risk of CHD significantly goes in. And of course, we are not truly yet sure about what the mechanism is. And there are some debates going on that maybe a high HDL, very high HDL, can be an indicative of a poor functioning HDL transportation. And in fact, it's interesting. We have an R01 working with our basic scientists where we've developed a new assay to look at HDL functionality. And that study design is looking at high elevated HDLs, those with calcium score of 0 and high calcium. So it's a very interesting space. So not every elevated HDL is reassuring. Just wanted to point that out.
And for me, that's a good indication to get a calcium scores. Yeah. Let's put some of this other stuff aside. A woman with a HDL in the 100 range, a man with an HDL above 80, I really start to question if that's cardioprotection or cardiac risk. And that's where, for me, a simple calcium score is very helpful. Clearly, that HDL of 97 is not protecting him, at least, in this case, for sure. Very, very high calcium score. I can't emphasize, this is not even the 99th percentile. This is the 99.9th percentile of calcium scores for a 60-year-old male. This is astronomically high. And I think Sydenham in the 1600s said a man is as old as his coronaries. This guy's coronaries are over 100 years old. So, if we don't do something about this, he's going down a bad pathway here.
Great, great. All right, and just a general statement about the colchicine. The patient has renal insufficiency, so colchicine may not be ideal for this patient. And of course, the colchicine studied in Lodoco was 0.5 milligrams, not 0.6. So inflammation certainly plays a role. All right, so just some general questions now. How are you utilizing the CAC score itself versus percentile? What role does percentile play in your decision making?
So CAC score itself is a better predictor of events, the absolute burden of calcification. We used the percentile for age, gender, and race, ethnicity to try to put it in perspective of where you are relative to other people your same age. And that's very helpful in younger patients where they don't have that calcium score of 100, but they're still ahead of the curve. And our guidelines, even going back to the 2018 cholesterol guidelines and the prevention guidelines of 2019 from HAACC, both advocate that if the percentile risk is above the 75th percentile or the calcium score is above 100, so it's an or statement, warrants therapy. And I think that's a nice way to put this in perspective. His calcium score of 1250, I don't need to calculate his percentile. I just pointed out that it's a remarkably high score for anybody.
Yeah, so the absolute scores is always going to prime the percentile, at least for the short, intermediate, and of the meaningful time frame that you're looking to guide therapies. And I can tell you almost 20 years back, there was a more emphasis on the percentile until a paper that was published in JACC. Matt was the first author that we showed that for the same percentiles, it was really how much plaque did you have, whereas if you accounted the total plaque burden, the percentile didn't make sense. So it has implications because if you're going to focus mainly on the percentile, then a 65-year-old with a very high calcium score may not meet the 75th threshold percentile, and a young person, you may want to treat them more intensely. The idea is focus on the total score. If it's high, treat them intensely. And for the younger one, to at least convince them to get on therapies early, because we're not thinking from the time frame of 5 to 10 years, but 20 to 30 year plus. So I think so the percentile are much more useful in younger population, but once your calcium score is high, then it doesn't matter.
Okay, great. Some other questions, I guess people still want you to expand on the warranty or the significance of a 0 CAC score.
Yeah, so
go ahead.
So no, I can tell you the power of 0. Look, what the concept of the power of 0 is, sometimes people confuse that the power of 0 means no risk. There's no such thing as no risk. What it says is whatever your guesstimated risk is, your risk is much lower where you can have flexibility. And the flexibility doesn't mean no statin. That's kind of a misnomer that exists in the journal media or within the Twitter circles. That means that for all of our patients, if they can go from no therapy to maybe low dose therapy, or we don't have to be as intensive. For a diabetic, that could mean just a low intensity statin. For a familial hypercholesterolemia or severe hyperlipidemic patient, that would mean you can start with a high intensity statin and you don't need to push with the PCSK9. So definitely the warranty for the 5 to 10 years is great. Now, like any other test, it's not once done test and you forget it. It all depends upon your risk. Based on MESA and other, we have suggested that if you're low risk and a calcium score of 0, as Matt has pointed in the prior cases, repeat the calcium scan again in 5 years. However, if you are a higher risk, a diabetic, elevated lipoproteinase, strong family history, or even severe LDLs like 190 or more, we tend to repeat them in 2 to 3 years. I think so that's the timeline. And of course, always have an opportunity to pivot. So yes, there's no such thing as a lifetime warranty, but For the 5 to 10 years, for the general population, it's great. And for higher risk, you may want to repeat them a little earlier.
And I would just say, I mean, the guideline says repeat and not to treat with a calcium score of 0 and repeat in 5 to 10 years. And some of that's even based off of my research, but I would say don't wait 10 years. Things change. Patients go through menopause. Patients develop hypertension. They might develop diabetes over that interim. I wait 5 years. The radiation dose of a calcium score is what the same as a mammogram. It should be about 0.6 to 1 millisievert. So, my boss 30 years ago told me that the calcium score was the mammogram of the heart, that we're going to use it to decide who to treat and who not to treat. And that's true. But you repeat a mammogram at some interval, and we need to repeat the mammogram of the heart, the calcium score at some interval. And I think 5 years is a pretty good number for most. And if they are enhanced risk, I think I agree with Dr. Nasir. I think 2 to 3 years and repeat it maybe at 3 years might be reasonable in some of the higher risk people. But doing it annually, never appropriate. Waiting 10 years, you might miss something. That might be a little too long. So I think 3 to 5 is a much nicer range for calcium scores of 0 to then decide to institute new therapy or to intensify therapy.
I think those are great points. So here's another question. Do you use CAC scores in your patients with FH?
All the time.
All the time.
I would say in patients who don't have established ACVD all the time. And the reason is that, again, it's a great tiebreaker on how intense we need to be. And, it started with almost 4 to 5 years when we did a meta-analysis and genetically confirmed FH and showed that actually almost 45% of middle-aged FH patients have a calcium score of 0. Followed by a study that was done by my colleague Raul Santos and ours that showed that, yes, even genetically confirmed FH, elevated LDL, almost 45% have a calcium score of 0 in 5 years. They have no events. And multiple other studies, Safe Heart, and now a 20-year follow-up study from Japan that was published in European Heart Journal this year that showed 40+% individuals with genetically confirmed FH have a calcium score of 0 and their 10-year event rate is pretty low. So based on that, the consensus, at least in this community, is at least within a small group is coming that, yes, of course, all of them need to be on a high-intensity statin plus minus Zetia. However, do we really need to push the intensity beyond that with the PCSK9 is questionable. So I can tell you that there are now many more publications. A lot of people are speaking about it. A lot of folks are doing about it. At least in our practice, most of these individuals with genetically confirmed FH or clinical FH get calcium scoring, and that guides them into the management, not for statin, but for more intensive therapies and aspirin and other items. So Matt, what do you think about
I agree. We have so many now studies. Mortensen, Dr. Mortensen published 11,000 patients with LDLs above 193 milligrams per deciliter. And that's lifetime. These were middle-aged people, and over 54%, over half, had a score of 0. And there was no increased risk. They looked at events. There was no increased risk of MI based on having FH or not having FH. It added no clinical value to risk prediction, although the patients who had a positive calcium score, FH was a 3-fold increased predictor of risk. So I think it tells us simply that not everybody is susceptible to LDL by itself. It shouldn't be taken in isolation. It should be put into the context of other risk factors. And I'm not very aggressive if they have a high LDL, even above 190, and a score of 0. I'm very comfortable treating them with a little bit of a statin maybe and lifestyle and keeping an eye on them. Whereas if they had a high score, I'd be adding PCSK9 for sure. I'd be adding ezetimibe for sure. I'd be pushing their statin up to the maximum tolerated dose, and I'd add an aspirin tablet to their regimen. So for me, it changes treatment dramatically. And I think it's really helpful to look at who's susceptible with LDL. And I would just point out that Mortensen from the Denmark Heart Registry published in Circulation last year really shows that the high LDL by itself was not a significant risk enhancer if their calcium score was 0, if they don't have atherosclerosis.
Okay, great. Quickie question here. Is calcified plaque ever reversible?
Probably not, at least not once it's established. I've seen low scores go to 0, but calcium is scar tissue. Once it's there, it's there. So our goal, if you are going to use it in any serial fashion, would be to not see it go skyrocketing high. Statins can slightly increase the calcium score by converting soft plaque to more dense calcified plaque. But if the score is going up by 25, 30% per year, there's a problem. You're laying down new atherosclerosis, you're plaque rupturing and getting that scar tissue. And I use that also as a trigger to be more intensive in my management of those patients.
No, thank you, Matt, for clarifying that. That's always remains a confusion within the medical community that statin increases calcification. And yes, it does by stabilizing and converting the existing plaque. But if the calcium scores is significantly increasing 20-25%, that's definitely a risk for newer plaques, and they need to be intensified and should not be equated to just the possible increase in calcification with statins.
That was a great answer, Dr. Nasir, because we have about 3-4 questions. What percent increase do statins contribute to a calcium score? I don't know if that's been calculated, but
not much.
Yeah. Okay.
Yeah, just under 10%. And that's been studied in many prospective randomized placebo-controlled trials with statin and no statin. That's a well-known. So double-digit increase is not statin effect anymore.
Okay, great. Another question, when would you switch over to a MESA risk score in these patients, or at all?
I think if you have a calcium score, the MESA risk score is helpful. It incorporates the traditional risk factors and then adds in race, ethnicity, and then adds in the calcium score. You don't need it in this case, 1,250. You don't need to do any risk calculation. The calculation is very, very high risk. But if you have a lower intermediate score, I think the MESA risk calculator is a nice way. It's easy. It's widely available. If you just type in MESA risk calculator and Google it, you'll come up with the calculator. There's an app as well. So I think it's a useful tool, gender and race ethnicity specific.
So, Matt,
sex and race ethnicity specific, excuse me.
I can tell you that I'm still a little agnostic about it. Number one, the MESA, of course, my colleagues and I've been significantly involved with all the activities. Mostly it's the score right now, it's the CHD rather than the complete ACVD. That's number one. But, I like to keep things simple. If your calcium score of 0, your 10-year risk is well below the threshold where the guidelines would even consider statin. And if you have atherosclerosis that has developed, especially at the younger age and irrespective, the process has started and your 10-year risk is above the threshold where one should consider statin. And once in a general population, it starts going above a threshold of 100, you're already CVD equivalent. So it becomes much easier to put things into perspective. So what we're seeing is you start with the risk score, add a calcium, then develop another risk score. I think from the patient's perspective, keeping things simpler is easier. At least it works well in our protocols in the clinic.
Okay, great. All right, here's a question. Calcium score of 0 in a patient with FH can be reassuring, but what about concern for other vessels as well as more soft plaque as seen in patients with very high LDL in FH?
I think in younger patients, I would, if you wanted to do a test, I would do a CT angio under age 40, 45. I think if you're going to do a test of atherosclerosis, a CT angio, even if they're asymptomatic, would be better because we worry about that false negative with younger patients. But I'm very reassured with a calcium score of 0. In MESA, we added ankle brachial index for a measure of PAD. We added carotid intermedial thickness and carotid plaque. as a measure of carotid disease, and it doesn't add much to a calcium score. It really is either nominal or not additive at all. So I don't think you need to do a 5 body part testing to be sure that they're okay. I think a calcium score of 0 is reassuring, and I would start them on low-dose statin and test them again in 3 years. If you're young, maybe carotid imaging, but use plaque and not intimal medial thickness, only carotid plaque as your metric. Carotid IMT is not a useful test and is a class 3 indication, should not be done. So you can look at carotid plaque, or you can look at CT angiography as an alternative strategy. Those are the only 2 tests that would even make sense to me.
Yeah, completely agree with Matt. I think that the notion of the non-calcified plaque in absence of calcium, in presence of calcium score of 0 is overblown. So we just published a study from 1,000 genetically confirmed FH across 7 countries. We find the same prevalence, about 15%, one single vessel, one streak of non-calcified plaque. And considering that if you're going to start them on a low to moderate or even high intensity statin, I'm not really sure that any minimal plaque in any other vessel may convince us or push us to intensify to a treatment like a PCSK9 inhibitor. Yes, I agree that if you have a very strong family history and in scenario where patients may not even want to go on a statin, then to convince the patient, or at least reassure myself and the patient, a CTA may not be a bad option. But overall, I would say those are going to be less than 1% of these cases.
Terrific. All right, in the next few minutes, I don't know, Matt, if you want to add anything, or Khurram, if you want to add anything for our general audience here and what they should think about when thinking about CAC scores and risk assessment.
I think we covered I think we covered a nice breadth of testing, when to rely on, when not to, the distribution of coronary calcium. In women, aortic calcium is a good predictor, a nice adjunct that you get for free if you look at the ascending aorta and descending aorta while you're looking at the calcium score. So don't forget about that. It doesn't add as much value in men, but you see a lot of aortic calcium. And I would just remember, and please, if you get a CT scan for another reason, rule out pulmonary embolism or low-dose lung cancer screening for the CTs, and you see a lot of coronary calcium, you know you have the disease. You don't need to quantify it. If you want to quantify it and get a CAC score, that's fine, but treat that patient. Don't let them go untreated. And hopefully, radiologists are reporting that more frequently. Presence of severe coronary calcium, or as an incidental finding, or moderate or minimal coronary calcium as an incidental finding. And I think that's a very helpful way to get some free looks. We do 90 million CT scans a year in this country. We should be looking at the coronaries, even if the test wasn't ordered for coronaries. It's the #1 cause of death for men and women.
Matt, thank you so much for summarizing all these pearls of wisdom and really highlighting the point that any non-contrast chest CT should be looked at, because that's easy, valuable information that shouldn't be overlooked, and what to do. The only takeaway message is what I really want everyone to understand. Why are we even doing the calcium testing? Because, in prevention, the basic foundation of our management depends upon one very simple but meaningful thing. Who is at your risk? And I would say, what is your risk? Because although if you have a patient with established CVD, there is little debate what intensity treatment, but the risk in asymptomatic cohorts are very heterogeneous. It's a large patient population. We can't treat everyone. We have finite resources. We have finite attention, and the patient needs to be done. And the reason why we're focusing on calcium testing of 2 reasons. One is the traditional way of assessing risk are extremely imprecise. That's been well documented. And secondly, this is not a risk factor. This is the disease, and the disease will always triumph risk. And clearly, for any data over the last 20 years have shown again and again and again, if you don't have disease, it doesn't matter what your risks are, your overall risk will be low. And if you have atherosclerosis and a high burden, it doesn't matter if you have lower risk, your risk of having an event is going to be higher. So clearly, in the patients population in your clinic, it is an amazing tiebreaker. So I would say use it more often, and I would be more flexible in ordering calcium testing, especially those with 40 years and above.
Terrific. I want to thank you tonight. You guys have been a great panel, all-star group, Matt and Khurram and Jonathan. Thank you for taking time out to join us this evening, and look forward to working with you again in the future. For those in our audience that have interesting topics or interesting cases, please email Amanda Hicks, ahicks@lipid.org. We're happy to have you present cases. We're happy to have you as panelists. We're happy to have you as moderators. So please join us. And again, thank you to this outstanding panel tonight. And everyone have a great evening. Thank you.